Hello, I'm Hillary Zachary, and I'm doing a case study on cervical pain. My patient is a 43-year-old male equipment operator working the night shift. His prior activity was working out 3 times a week. Examination date was November 28, 2013, and a physician referral for cervicalgia. His chief complaint was numbness and tingling down his right arm since August 2012. Date of injury, it was insidious onset, and these are self-reported scores. His primary complaints, P1 was numbness and tingling down right arm, intermittent variable, going from 5 to 7 out of 10 pain. P2 is deep pressure in the anterior aspect of shoulder, constant variable, 2 to 5 out of 10 pain. P3 is ram's horn headache, dull ache with some movements, and that was 5 out of 10 pain. My patient is experiencing numbness and tingling, and I feel like there's a relationship between P1, P2, and P3. So joints under the area of symptoms that the pain could be coming from: cervical spine, glenohumeral joint, scapular thoracic joint, and thoracic spine. Structures that may refer to the area is liver, gallbladder, heart, and lungs. Contractile tissue is upper trap, levator scap, pec major, suboccipitals, and other structures could be cervical nerve root. My primary hypothesis is cervical radiculopathy. Secondary hypothesis is cervical facet dysfunction. My patient's aggravating and easing factors. P1 aggravating factors is cervical movement causing numbness and tingling lasting around a minute before symptoms decrease, and gripping activities. Easing factors, ibuprofen. P2 aggravating factors is lying down or sitting for greater than 20 minutes, producing 5 to 7 out of 10 pain. Easing factors is getting up and moving. P3 aggravating factors is cervical movement causing headaches lasting around 30 minutes. Easing factors, ibuprofen. My patient's sleep and 24-hour pattern. His symptoms best after work and worse in the AM. Patient was receiving 3 to 5 hours of sleep at night due to his work schedule and taking care of his 5-year-old son. Duration of current symptoms, 3 months. Mechanism of injury is insidious onset, and progression since current episode, it's been about the same, and he has no significant prior history, and he did receive a steroid injection prior to. So medical history, comorbidities is cleared. He had no red flags or yellow flags, and he did have an MRI on his cervical line showing a herniated nucleus pulposus at C3, C4. Medication is ibuprofen. So the asterisk signs that I'll use from the history is P1, numbness and tingling with 5 out of 10 pain immediately after turning head to the right, lasting for about a minute. P2, lying and sitting down for greater than 20 minutes with 5 out of 7 out of 10 pain. P3 is headaches with cervical extension lasting 30 minutes. So my primary hypothesis is cervical radiculopathy, and secondary hypothesis is cervical facet dysfunction. So what I got from the history I could rule out for musculoskeletal is peripheral nerve entrapment, and for non-musculoskeletal, cancer, gallbladder, or liver dysfunction. The severity of my patient's condition is moderate to severe due to his easily reproducible symptoms with neck range of motion and pain during work and ADLs, but this does not prevent him from work or his ADLs. The irritability of his condition is moderate to severe, with numbness and tingling reproduced with minimal activity. The primary nature of the problem is nerve involvement with moderate to severe muscle tightness reproducing headaches. The stage of the disorder is chronic, and the current stability is stable and reproducible. To rule in or rule out my hypothesis, I'm going to use Sperling's cervical compression and cervical distraction and upper limb tension. So my physical exam, there was no precautions or contraindications. Postural observation was moderate forward head and rounded shoulders. A quick screen, I cleared the glenohumeral joint and thoracic spine. And the neurological exam was clear, and his range of motion, cervical range of motion with flexion was 50, extension was 25, reproducing headaches, 2 out of 10 pain. Right side bending reproduced P1 and P2, and right rotation produced P1. And left side bending was 30 degrees, and then left rotation was 5 degrees. So my patient had tender to palpate over the levator scap, upper trap, and his scalenes. And his joint restriction, I did cervical, central PAs, and he was hypomobile and painful throughout. And for muscle testing, I test his grip strength, which was on the left was 103 pounds and right 83. And I test his lateral pinch, which was 24 pounds on the left and 25 on the right, and the 3 jaw pinch, which was 26 on the left and 21 on the right. His gross assessment for upper extremity MMT was about 5 out of 5. Muscle length, he had scalene, levator scap, upper trap, pec major tightness. And special tests that I did, the ones that were positive was the upper limb tension test. Traction relieved his symptoms when compression reproduced it, and Sperling's test was positive. My primary hypothesis following the physical exam is cervical radiculopathy. My historical asterisk signs that I found is numbness and tingling in the right upper extremity reproduced by cervical movement, and that his symptoms were worse in the AM. The things that I found in my physical exam is positive right Sperling's test, symptoms reproduced with compression, symptoms relieved with cervical distraction, and a positive upper limb tension test A with the greater than 15 degrees difference of cervical rotation from side to side. Prognosis for this patient's good with PT intervention and patient compliance. Estimated about 4 to 6 weeks of physical therapy. I will see this patient 2 times a week for 4 weeks, and my patient-specific goals is gaining his grip strength back and performing ADLs pain-free. I will know that my patient is ready for discharge when his subjective and objective goals are met. And if my patient's not making progress, I will stop treatment around 3 weeks or when all other treatment options have been explored. My overall management strategies is mechanical cervical traction, thoracic manipulation, deep neck flexor training, and increase his flexibility and cervical mobility. Any questions?